The alarm has gone off and you are awake. You have been in bed for 8 hours. 8 hours of lying still, of being unconscious for most of them, of doing the one thing every piece of sleep advice has told you is the solution. You went to bed at a reasonable hour. You did not stay up late. You gave your body the time it was supposed to need. And you feel terrible, not the groggy, tolerable tiredness of a short night, the kind that coffee can address. Something heavier than that. A physical flatness behind the eyes. A weight in the muscles that hasn't lifted. The specific exhaustion of a body that went through 8 hours of the motions of sleep and came back from them no more repaired than when it left, as though you were unconscious, but the work that sleep is supposed to do simply did not happen. You have been told, more than once probably, that you should sleep more, or sleep earlier, or practice better sleep hygiene. You have likely tried some of these things. The hours in bed have not been the problem. The problem has not moved. That is because the problem is not the number of hours you are spending in bed. It is what is happening, or failing to happen, inside those hours. And almost no one has named it clearly for you. In this video, I am going to show you exactly what your body needs from sleep, that it is almost certainly not getting, why it is not getting it, and what can be done about it. Not generally, specifically. At around the 9-minute mark, I am going to tell you about a condition that affects somewhere between 50 and 70% of adults over 65. A condition that produces exactly the exhaustion this video is about. That is almost never looked for in older adults because the symptoms are attributed to age, and that in most cases is completely and immediately treatable. Most people watching this video have never been tested for it. A meaningful number of them have it. I have spent more than 3 decades in geriatric medicine, and the complaint in this title, exhausted after 8 hours of sleep, is one of the most consistent things I hear from patients in their 70s and 80s. And the most consistent failure I see in how it is managed is the assumption that the hours are the problem. They almost never are. The architecture is. Let me explain what I mean by architecture. Sleep is not a uniform state. It is a structure, a cycle of distinct stages that repeat across the night, each serving a different biological purpose. The stages you are likely aware of are light sleep, deep sleep, and REM. But the specific stage that determines whether sleep is restorative, the one that separates 8 hours of rest from 8 hours of genuine biological repair, is called slow-wave sleep. Stage N3. Deep sleep. Think of it this way. Your body was designed to spend significant portions of each night in deep water. Slow-wave sleep is where growth hormone is released, the signal that drives tissue repair, muscle maintenance, and cellular regeneration throughout the body. It is where the glymphatic system runs its most efficient brain-clearing work. It is where the immune system consolidates and where the stress hormones that accumulate during the day are most effectively suppressed. The deep water is where the body actually does what sleep is supposed to do. After 65, almost everyone is spending the majority of their night in the shallow end. The proportion of sleep time spent in slow-wave sleep declines with age, steadily, measurably, from approximately 15 to 25% in young adults to 5 to 8% in adults over 70. In some older adults, slow-wave sleep is effectively absent. 8 hours of sleep with no significant slow-wave sleep is not 8 hours of rest. It is 8 hours of the body cycling through light stages, close enough to wakefulness that nothing meaningful is completed, and emerging each morning with the sensation that the night accomplished nothing. Because biologically, it largely did not. The growth hormone that should have been released was not. The tissue repair that was supposed to happen did not begin. The inflammatory burden of the previous day was not suppressed. The brain was not adequately cleared. And the body emerges from bed carrying yesterday's unfinished biology into today, on top of whatever today will add. This is what the research shows. And there are 3 specific reasons why slow-wave sleep disappears after 65, only one of which most people have been told about, and only one of which gets named clearly for them. The first is the natural change in sleep architecture that comes with age. The brain's slow-wave generating mechanisms weaken over time. This is a real, documented biological change. It is the one factor most physicians are aware of and the one most likely to produce the response, "This is normal for your age." And while it is common, Common does not mean it cannot be addressed or that it is the whole picture. The second is something that is present in the evenings of a very large number of older adults, something that is almost universally regarded as harmless, and is, for many people, part of a deliberate strategy for improving sleep. A glass of wine, a small drink before bed, something to take the edge off the evening and ease the transition into sleep. Alcohol is a sleep aid. Functionally, in the short term, it reliably shortens the time it takes to fall asleep. And this is precisely why it has become part of so many older adults' evening routines. It works, except it does not. What alcohol does to sleep architecture is the opposite of what the body needs. In the first hours of sleep, the first half of the night, alcohol promotes lighter sleep stages and facilitates the initial loss of consciousness. But in the second half of the night, as the body metabolizes the alcohol, it rebound activates the brain's arousal systems. Sleep becomes fragmented. REM sleep is disrupted. And slow-wave sleep, the deep sleep that was already reduced by age, is specifically suppressed by alcohol in ways that are well documented in the sleep literature. The person who has a glass of wine to help fall asleep is using a substance that accelerates the transition into the shallow end while ensuring that deep water remains inaccessible. The hours accumulate. The sleep feels like sleep. The morning brings the same physical flatness it always does. And the attribution is age, not the intervention that removed the possibility of restoration. Now, I want to tell you about a patient I worked with. No name, because her story is specific enough to feel like one person's, but common enough that it belongs to many. She was 73 years old. She slept 8 hours every night, consistently, deliberately. She had tried everything. Consistent bedtime, no screens after 8, chamomile tea, the full list. She slept alone, had for several years since her husband's death, in a quiet house. She was exhausted every morning. Her primary care physician had attributed it to aging, to the depression of bereavement, to the reduced physiological vigor that is expected at her age. Someone who knew her, a relative who was a physician, asked a single question she had never been asked before. Not about her sleep hygiene or her bedtime or her screen time, about whether she ever noticed her breathing changing while she slept. She said no. She slept alone. There was no one to notice. She was referred for a sleep study. The results showed 27 apnea events per hour. In each of those events, she briefly stopped breathing, 10, 15, 20 seconds, long enough to produce a microarousal, a brief return to wakefulness she would not remember in the morning. Her body, in its instinct to breathe, was pulling her out of the deeper sleep stages every 2 minutes, on average, throughout the night. 8 hours in bed, hundreds of microarousals, almost no slow-wave sleep, no restoration, no repair. With CPAP treatment, a device that maintains airway pressure during sleep and prevents the apnea events, her fatigue began resolving within 2 weeks. Not gradually, not partially. She described the first morning she woke genuinely rested as the most significant health change she had experienced in 5 years. The exhaustion that had been attributed to age, to grief, to the inevitable decline of an aging body, had a source. And the source was treatable. Now, the 9-minute mark. The condition I told you I would name. Obstructive sleep apnea. A condition in which the upper airway collapses partially or completely during sleep, blocking airflow, producing the arousal response that fragments sleep architecture. In younger adults, sleep apnea has a recognizable profile. Usually male, often overweight, usually accompanied by loud and reported snoring. Physicians are trained to look for this profile. In adults over 65, the profile is different. Sleep apnea in older adults is less likely to involve dramatic snoring. It is more common in women. It is more likely to present with fatigue, cognitive changes, and morning headaches than with the obvious respiratory symptoms that prompt a referral in younger patients. And the person living alone, which describes a significant proportion of adults over 70, has no one to notice or report the breathing pattern. The research puts prevalence of sleep apnea in adults over 65 at somewhere between 50 and 70%, not 50 to 70% of those with risk factors. Of all older adults, the majority, undiagnosed in most of them, because the triggers that prompt testing in younger patients are absent, and because the symptoms, exhaustion, cognitive fog, reduced physical stamina, are routinely attributed to the aging process rather than to a treatable condition. A home sleep apnea test is now available in most markets. It is covered by most insurance plans when ordered by a physician. It does not require an overnight laboratory visit, and the conversation that leads to it begins when the patient asks, not when the physician offers. In most cases, when the patient asks. You now know to ask. Here is what I want you to hold before the protocol. The hours in bed are not the problem. The architecture inside those hours is. An architecture, unlike the passage of time, can be examined, measured, and changed. The slow-wave sleep that your body needs is not gone because of your age alone. It may be gone because a condition is fragmenting it, because a habit is suppressing it, because a factor that no one has looked for is preventing the deep water from being reached. That is different from age. That is addressable. 3 things. Each one opens a different possibility. The first is the sleep apnea conversation. At your next appointment with your physician, say this: I would like to discuss whether I might have obstructive sleep apnea. Say it by name. Sleep apnea in older adults is systematically undertested because the symptoms look like aging and the profile does not match the expected patient. Your asking is what changes that. A home sleep test can be ordered at the same appointment. It requires sleeping with a small device on your wrist and a sensor on your finger. No laboratory, no overnight stay. If your result shows apnea, CPAP therapy is the most effective treatment known for this condition in adults of any age, and the resolution of sleep apnea exhaustion in older patients is often among the most dramatic health improvements I have seen in practice. The second is the 10-day alcohol audit. If you regularly have an alcoholic drink in the evening, even a single glass, even wine, commit to 10 days without it and track your morning restoration score on a simple 1 to 10 scale each morning. This is not a judgment about alcohol. It is an experiment. The suppression of slow-wave sleep by moderate alcohol consumption is well documented, but the individual variation is significant. Some people are more affected than others. The only way to know how much your evening drink is contributing to your morning exhaustion is to remove it temporarily and measure what changes. 10 days. One number each morning. The data belongs to you. The third is the morning resistance training anchor. Of the lifestyle interventions studied for restoring slow-wave sleep in older adults, resistance exercise, not cardiovascular exercise specifically, but resistance training, weights, resistance bands, body weight exercises, has the strongest evidence base for increasing deep sleep duration and improving sleep efficiency in older adults. A meta-analysis of resistance training and sleep quality found meaningful improvements in slow-wave sleep duration when exercise was performed 3 or more times per week. The timing matters. Morning or early afternoon exercise produces the strongest improvement in evening slow-wave sleep. Evening exercise within 2 hours of bedtime can disrupt sleep onset. 3 sessions per week, 20 to 30 minutes each, at an intensity appropriate to your current fitness level and discussed with your physician. Go back to where this video began. The alarm has gone off. 8 hours in bed, the specific heavy exhaustion of a body that spent the night in the shallow end of the pool. That exhaustion is not the price of getting older. It is the signal of something that has not been examined. A treatable condition affecting the majority of older adults going undetected because the symptoms look like aging. A common evening habit suppressing the sleep stage that aging has already made scarce. A specific targeted exercise intervention that the research says can bring some of the deep water back. 8 hours means nothing if the architecture inside them has collapsed. The architecture can be measured, and once measured, it can be changed. If someone you know has been waking exhausted after a full night's sleep and has been told this is simply what aging looks like, please share this video with them. Because slow-wave sleep can be assessed, sleep apnea can be diagnosed, and the difference between waking rested and waking depleted, for a meaningful number of older adults, is a conversation that has simply never been started. Tonight, and for the next 2 nights, I want you to try something before you reach for your phone in the morning. The moment you become aware that you are awake, before coffee, before speaking, before the day begins, give yourself a number from 1 to 10. 1 is feeling completely unrestored, as though the night accomplished nothing. 10 is feeling genuinely refreshed, ready for the day, without resistance or reluctance. Write down the number. 3 mornings. 3 numbers. Because next week I am going to explain what those numbers likely reveal. Specifically what restoration scores look like in people with undiagnosed sleep apnea, what they look like in people whose slow-wave sleep is being suppressed by alcohol, and what they look like in people whose sleep architecture has declined through age alone. The pattern in your 3 numbers is not a diagnosis, but it is a conversation starter, and next week's video will tell you exactly what conversation to start. Come back with what you find. One important note before you go. Everything in this video is for educational purposes only and is not a substitute for the guidance of your personal physician or a board-certified sleep specialist. Sleep apnea is a medical condition that requires proper evaluation and diagnosis. A home sleep test ordered by your physician is the appropriate first step, not self-diagnosis. The alcohol audit and exercise recommendations in this video are appropriate for most healthy adults, but should be discussed with your physician if you have conditions that affect your activity level or medications that interact with alcohol. Please bring this video's questions to your next medical appointment. They are the right questions for that room.